This is Brian Wormers recording a lecture for medical surgical nursing on assessment and care of patients with ear and hearing problems. Here are learning objectives, same as on the PowerPoint. So some assessment techniques that you might want to do would be looking at their posture and their appropriateness of responses. Are they posturing so that they're turning their ears towards you so that they can hear? Are their responses appropriately for what you asked? Patient history, do they have a history of pain, discharge, vertigo, ringing in the ears, any difficulty in hearing or understanding? Any recent trauma, surgery, infections, other past medical history, any medications? All these things can play a factor in their hearing. What's their family history? Do they have a family history of having hearing loss? Any other current health problems, such as an intolerance of sounds, any ringing of the ears, or any vertigo? So physical assessment, looking at the external ear and the mastoid. So is the shape intact? Is it equal bilaterally? Is there any tenderness? On otoscopic examination, so can you see any earwax in the ear? Is the tympanic membrane pearl gray and appropriate color? Can you see the ossicles and the different bones within there? So the way to use that otoscope is you basically hold it upside down with the handle pointing up, and then you pull that pinna, the ear, up and back for adults, and so that gives you the best view. Auditory assessment, so you can do a voice test and see what they can hear. You could also do fancier hearing tests, looking at conductive, sensory, neural, or a mixed. So some of this will include the Weber and Rinne. So Weber is here when you put it on top of their head, remember, because it looks like half of a W, and you're trying to see if they can hear this out of both ears. Rinne is putting it here and seeing if they've got conduction so they can hear at that mastoid process, or is it better through the air? Diagnostic assessment, so other lab tests. We can look for any toxicities or something like that. We can look at imaging to see if there's any tumors or blockages or fractures. We can do auditory assessments, including tympanometry. We can do BEARS, which is brainstem evoked auditory response. Your book's got it listed like this, but I've seen it more commonly as a BEAR. We can do electron nystagmography, which I haven't seen in real life. And then we can also do caloric testing, and this is a brain death criteria, so in which you put cold water into your ear, and that elicits a response. I do not recommend you guys trying this because it tends to cause nausea, vomiting, vertigo in somebody that's alive, so don't try this on your buddies. So changes associated with aging, you're going to get drier, more impacted earwax. You're going to have a loss of tympanic membrane elasticity and movement of the ossicles, so that's going to decrease your auditory ability. We're also going to see some changes of the cochlea, vestibular function, and hearing acuity. Also tend to have a decreased ability to hear high frequency sounds. Otitis externa or external otitis, either way. This is a condition of you get irritation on the outside of your ear, and it might be called swimmer's ear. Commonly happens in hot, humid conditions. Prevention, basically you can put some alcohol in there to pull out the water and dry the water. Otherwise, I've used oil and vinegar to make it an acidic environment so the bacteria doesn't want to grow in there. Treatment, of course, is to try and prevent the inflammation, the edema. So like a topical antibiotic along with a steroid to reduce any swelling, and then analgesics to decrease pain. A furuncle, so this is a bacterial infection of the hair follicle. So this can be in and around that ear. And once again, treatment is antibiotics, heat application to try and get that to pop, and then trying to reduce pain. Earwax or foreign body, so this is the most common of reason for hearing loss is you've got something in there, whether that is beads or pencils, insects, what have you. So it's very common. We see this a lot in kids, but we also see it a lot in the adults too. If you suspect that this is a vegetable matter, such as plants or anything like that, try not to infuse any water into it, as it might cause that to swell. If you're talking about an insect or something that crawled in there, oil would be a good thing because it slows the movement down and it can suffocate it. And then once it's suffocated, then you can try to remove it, because if you try to grab onto it and remove it, it tends to make the insects angry, and that's not something that patients generally like. And then, of course, remove said foreign object. With earwax, you can use an irrigation syringe, or what I've seen is like a normal saline syringe and taking an IV catheter and just using the catheter part, not the needle part, and then injecting saline. And basically what you want to do is you want to inject it into this space back here, cause it to come back and out, and then when it pressures back, hopefully it removes this earwax with it. Otitis Media, we'll talk about this more when you guys have pediatrics, but you can have acute, you can have chronic, or you can have blood. So it's less common in adults than in kids. But here we can see that there's fluid in here as present by, there's an air bubble here. You've still got your cone of light, and you can still see some of your bony stuff, but you've still got fluid there. This is a ruptured tympanic membrane, so you can see your bones all too well. And so oftentimes it was pressure behind that caused that. Oftentimes they've got pain, they've got a sensation of fullness, they can have some hearing loss with that, it can cause some headaches, nausea, vomiting, dizziness, and vertigo. Often that eardrum is red, thick, and bulging with lots of landmarks. Management, quiet environment, bed rest, limit those head movements so they don't get the vertigo. You can do heat or cold applications, whatever feels better to them. Antibiotic therapy is usually a hallmark of this if we think it's bacterial in nature. Analgesics, antihistamines are a good one because oftentimes it's plugging of a eustachian tube, and if you can get that to relax and open up, then that fluid will flow through there better. And same thing with the decongestants. Surgical management, so you can do a myringotomy, which is just a surgical incision into that, causing it to drain. You can also include an grommet with that, so basically this is your PE tubes or tubes into that ear. Post-operative care, most of the time they're pretty basic with their care. Just try and let it heal for several days. You might include some antibiotic drops, but usually not. We don't want them drinking through a straw initially because it can displace that, but after 2 to 3 weeks then they can. Mastoiditis, this is an infection of that mastoid air cells. There's a lot of pain, a lot of swelling, and redness. May develop a cellulitis. Non-surgical management of this generally, and we're using antibiotics. Trauma to the eardrum or ossicles can be from cotton-tipped applicators, so Q-tips are probably the most common, otherwise cannuling, otherwise through rapid changes, so barrel trauma. If they go diving, if they are around gunshots or explosives or anything like that. Perforations will generally heal within 1 to 2 weeks. And they might have some permanent scarring which will affect that eardrum. Biggest thing we do is try and protect it from the trauma. So if you're using a gun and shooting, put the hearing protectors on. If you're at a loud concert, once again, hearing protectors are good. Cauliflower ear or boxer's ear. So you're seeing trauma to this ear causing inflammation and swelling. If you do not drain that fluid out, that causes calcifications in this ear, and you get a long, lifelong look like this. Drainage of it, just using a butterfly and pulling it out through a syringe. Tinnitus is a ringing of the ears, and so what we're seeing with this is it's a common problem, but it can be very quiet or it can be very loud. So it's really hard to treat just the tinnitus. You've got to probably treat the underlying cause, and so that's really what your mainstay is. The other thing you kind of do is mask that tinnitus with some background noise or noisemakers. And then, especially during sleeping hours, when you've got nothing else that you can really focus on, that ringing tends to become even worse. Vertigo and dizziness, so common manifestations of this. Vertigo is a true sense of whirling or spinning in space. Dizziness is just kind of a lightheaded type of a thing. So what's going on here is you've got cochlear and semicircular canals, and you've got an alteration with that one. So this can be either from the little things inside of there that are messed up, or this could be drug related or a variety of different things. So things we want to do is try and restrict those head motions. We want to maintain adequate hydration because it's that lymphatic tissue in there. And then also they can take some antivert, But if they do take some antivert drugs, then make sure that can cause some sleepiness and drowsiness. So operating heavy equipment, driving, those kind of things can be very dangerous then. And then also try to prevent loss of balance accidents. So, if they're taking this and they've got vertigo, maybe they shouldn't wear the high heels right away, and they should take care of themselves and make sure that they're not at a fall risk. Ménière's disease is a combination of these things. So you've got ringing in the ear, you've got hearing loss, and you've got vertigo. So it's not much fun. Most patients do not enjoy this at all. But you're talking about an excess of endolymphatic fluid, and we're not exactly sure why this happens. Some of the treatment methodology can include this high drops diet, so if you click on this, it will explain it a little bit more. We can use drug therapy trying to get rid of some of that lymphatic fluid using diuretics or antihistamines. We can use antiemetics if they're nauseous. We can use some gentamicin steroids to reduce some of the swelling. Ultimately, the final treatment would be a Ménière device, and that applies some low pressure micropulses to the inner ear. Surgical management is definitely the last resort. The problem is that you will often have hearing loss because of the procedure. But you're taking out part of that labyrinth and then decompressing some of that endolymphatic. So hearing loss is one of the most common physical handicaps in North America. It can either be by conductive hearing loss or sensory neural, or a combination of the two. So here's kind of where it explains it. So external ear, internal ear, and so this is how you get conductive versus sensory neural, or it can be a combination of the two. Types of interventions, we can look at medical interventions. So early detection, of course, with anything is going to be the best. But we want to have some safety measures due to hearing loss. Think about all the things that you have for alerts, your phone, the beeping of the microwaves, the beeping of your monitoring in the hospital. All those things are safety alerts that are auditory, and if you can't hear those, it puts you at risk. We can do dietary considerations, so oftentimes we want to push lots of fluids in this and make sure that they've got good hydration. We can give different medications to try and help. Surgical, we can do hearing aids, which are implants. Otherwise, we can even do cochlear devices and cochlear implants. Communication aids, such as hearing aids. Once again, we can do lip reading, sign language, speech therapy. And then for community resources and psychosocial resources, it would be support groups. So this concludes the presentation on hearing and hearing loss. If you have any questions on this, please contact your professor.